and Dr. Abhyankar, Dr. Arjun, they're all been I've learned a lot from them. And uh, and as you can see, they're like, I hope the audience who are logged in can ask as much as questions and learn from their experience as well. There is silence where Dr. Goel is.
Yeah, I think Dr. Goel is silent. So
Silent, yeah.
I think he's logged out. So I think let's kickstart the whole idea of
Yes.
So I joined in.
Dr. Goel has joined in.
He joined in.
So something happened.
Yeah.
Not sure how it happened, but anyways. So one thing I can tell you about Dr. Shyam is that he is an excellent interventional pulmonologist, one of the most courageous interventional pulmonologists, and he showed me a case of football size mediastinal cyst. A patient who was not fit for anesthesia, not fit for surgery, and he managed this case beautifully by EBUS bronchoscopy. So heads are off to you, Dr. Shyam Krishnan, and you do a lot of innovative work. And of course, the pulmonology is quite safe with the people and people like you, Arjun, around. So India has come a long way in interventional pulmonology, but you are creating the future and the flag bearers of interventional pulmonology. So with these words, we are set for the panel discussion, and of course, a lot of information has already been shared. So I would start with Abhyankar, because he's the most senior and the most experienced medical thoracoscopist in the country. So I would like to know from you, Dr. Nitin, what kind of infrastructure would be required to initiate a rigid thoracoscopy program in an institute for a beginner?
Very frankly, in today's scenario, I think the fact that you can't afford a flexi-rigid will be the best indication. So I think, well, I mean, I'm putting it in a funny way, but at the same time, I think anybody, anywhere who has access to laparoscopic instruments, that's one, has some kind of access to operation theater in one way or another, is able to start the setup. So I don't think you require a great depth of infrastructure. You have to imagine that the laparoscopic instruments are a little longer and our instruments are a little shorter. So you'll need some kind of adjustment in that. And your biopsy forceps have to be little larger cupped and little larger, bigger and larger in size. So if you really see the infrastructure from the point of view of infrastructure, I don't think it's so difficult, because most of the, say, tier 2 cities in this country have a bronchoscopy suite. And even in a bronchoscopy suite, a thoracoscopy, which is diagnostic, pure diagnostic, can be very easily done even in the absence of anesthetist. So the infrastructure requirements are not too many, but one has to know what are we aiming at. If I'm purely doing a diagnostic interventional thoracoscopy, medical thoracoscopy, midazolam, fentanyl, that's my limitation, then rigid or flexi-rigid, it doesn't really matter. What you need is a correct kind of sterile techniques, and the sterile techniques is something which physicians have to learn actively. Very frankly, every single fellow of mine, we have had 37 of them, they had to be initiated into the thoracoscopy suit differently. Bronchoscopy mein they were comfortable because वो mask और gloves डाल के अंदर जाना है, कुछ नहीं करना है. Because every physician is trained differently, every surgeon is trained differently. We have to behave like surgeons, and that is very important. So I think that sterile, surgical, drapes, gown, gloves, all that attitude, mask, everything, the whole thing has to come in place, and that doesn't take much. It only takes the change in the attitude. And very frankly, that is not an infrastructural change, it's an attitudinal change that has to be brought in. If you are getting into a thoracoscopy suit, you behave like as if you are really going to operate a big tumor. It doesn't matter whether you land up doing that, you don't land up doing that, you are going to do mostly biopsies, but that's enough. But or you do a talc powder agent come out, but at the same time the precautions are the same, and therefore that attitudinal change is the biggest infrastructural change I would look forward to.
Thank you, Dr. Nitin, for such nice way of putting this issue. So many times, the beginners think, oh, we don't have the infrastructure, we can't do it, but you can do it with the basic infrastructure which is available in your setup, and just need to be more careful and know especially the aseptic precautions like a surgeon. So you have to, as a pulmonologist, also behave like a surgeon. So that is the key message from you. So now I ask a very basic question to Dr. Swami Pawar from Bombay. Medical thoracoscopy is actually an extension of, the chest tube drainage and thoracocentesis. And majority of the time, you are able to get a diagnosis by doing a thoracocentesis itself. So what would be your indications for doing, medical thoracoscopy?
Conventionally, when you do approach a pleural effusion, most of the time, 60 to 70% times, the pleural fluid analysis will give you the results. It is the undiagnosed where the diagnosis is not very much clear. It is the time when you will go for a medical thoracoscopy or a thoracoscopic diagnosis, pleural diagnosis. Most of the time when you have a dilemma, whether it is an infective or a malignant pleural effusion, that is the time when you will do it. The other indication for the medical thoracoscopy, especially in a pneumothorax, when you have a recurrent pneumothorax and when you basically miss out on small blebs and bullae on a conventional CT. Medical thoracoscopy can actually identify those things very rightly. Even those patients who have recurrent pneumothorax, they are the people who you should be aiming to do a medical thoracoscopy and provide them a therapeutic advantage of talc powder.
So that's very rightly said. So any undiagnosed exudative pleural effusion, which you're not able to diagnose with routine thoracocentesis, and where there is a high probability of having a malignant lesion, where you want to have a larger biopsy pieces for immunohistochemistry and also staging of the lung cancer, then this becomes a very important and in fact the mandatory sort of a procedure to do it. So very well said. And I would now ask Dr. Pratibha, what would be the contraindications when you would not like to do a medical thoracoscopy?
Yeah, the contraindication for the beginners would be any bleeding diathesis you shouldn't do. And more than that, before starting, because taking up the procedure, you must think about the pleural space, if the pleural space is adequate or not, because the rigid setup needs a liberal pleural space. Either we create it by creating a pneumothorax or we have a moderate effusion at least. If we have a very limited effusion, sometimes we have done the thoracoscopy when patient has just 50 cc or 70 cc, but we have created a pneumothorax. So we see that our lung is collapsed and we have space for our equipment to be accommodated. So for the beginners, the most important contraindication would be absence of a pleural space. So just be very sure bedside or on-site ultrasound will help you do that. If you have more skillful, then as Dr. Nitin Abhyankar said, he used to use a Botin needle to create a pneumothorax. We use a simple 50 cc syringe, a cannula, and a 3-way to introduce a pneumothorax.
I think we talk about the standard practice. We talk about the simple basic rigid thoracoscopy. So what would be the contraindication in those cases?
Then we must look for any bleeding diathesis. We should not do that. If patient is hemodynamically unstable, we should not do that. If patient is having hypoxia, we should avoid doing that, because patient lying in a lateral decupitous position sometimes changes the hemodynamic, the return to the heart very badly, and there are more chances of complication. So broadly speaking, we have 3 or 4 complications when we should not take up the patient for a rigid thoracoscopy. One is small pleural space, second hemodynamic instability, third hypoxia, and a bleeding dyscrasia or bleeding diathesis is an absolute contraindication.
That's very nicely said, Dr. Pratibha. And one of, I think, important contraindication, a relative contraindication would be very obese patient, where you may not dissect the chest wall enough, and the trocar and cannula may not be right, enough length to reach the pleural space. So that would be one additional contraindication. So that's very well said. And you would do a procedure in a patient who is able to lie flat or in a position for at least 1 hour without any discomfort. So you want a very stable kind of a patient. It's not an emergency procedure. You have to do it a procedure as an active procedure, and where your patient has to be stable. So
another relative contraindication, Dr. Manoj, would be a patient who has lots of cough. So when you use the trocar or the instrument inside and the patient coughs, the lung expands and you lose the pleural space. And there are more chances of surgical emphysema in such patients.
So cough is a very big problem, especially when you're doing a thoracoscopy, where the complication rate would go up and the procedure itself becomes very, very difficult. So cough management is extremely important while doing a thoracoscope. So they're very well said, Dr. Pratibha. Now I would ask Dr. Shyam Krishna. So you have got a case where you think you can do a medical thoracoscopy in this patient, but still you would be a little reluctant, and you would ask your thoracic surgeon friend to do it. So who are the cases who you would refer for thoracic surgery? For doing medical.
So one is, So the cases I would usually seek a surgeon's help is basically if, like Dr. Gogia said, if you have extensive fibrosis that you can't delineate the plane, you don't know where the pleura starts and where it's how much it's extending. Those cases I wouldn't touch at all, because you need to find a plane. Arjun does it well because he's an expert. He's almost like a surgeon. But those are the cases I would kind of refrain from, where you have extensive fibrosis in the pleural space, where you can't find any gap where you can actually put in a trocar, or you don't find any gap. The second one I would be reluctant to go in would be if I find a thick visceral rind as well. The parietal pleural is thickened plus the visceral rind. Those are the cases where the surgeons would do a better job at doing the decortication as well in the same sitting. So any complicated empyemas, stage 3 and beyond, I would happily refer to the surgeon. Fibrothorax, where I can't find adequate space, then CKD patients, empyemas, loculated effusions in CKD patients, they bleed a lot. And I've had trouble, I spent hours controlling the bleed. So they are the ones whom I would happily refer to a surgeon. And the rest, I think, so we can manage. So these are the basic cases which I wouldn't be happy to do.
So,
Dr. At the same time, can I come in for a minute? I mean,
yes,
please.
Yes, please.
Shyam, what you said, the last sentence, where you said, somebody with a creatinine which is high and uremic, and the surgeon will very happily refuse in any case. So, in any case, the ball is back to you.
I think I can say very well said, Dr. Nitin and Dr. Shyam. Anytime that you feel not confident that you'll be able to do the procedure safely and you will not come out with the result, and you're not able to possibly handle the complications should they arise, then these are the cases where you should refer to the surgeon who is much more experienced, has got much more expertise and the facilities to, take care of these kinds of patients. So, and one case of, as Dr. Pratibha said, with patient who is coughing a lot, where you are not able to control the cough, possibly these are the cases who would require anesthesia or maybe a single lung ventilation, where the and the surgeons can come to your rescue. So, Dr. Arjun, you talked about the bleeding tendency and coagulation profile of these patients. We know that is an elective procedure and there is standard guidelines for interrupting the anticoagulation. So what would be your advice if somebody is on antiplatelets and anticoagulants before doing the thoracoscopy, and how would you interrupt these anticoagulants and antiplatelets?
We would like with the bronchoscopic procedures. So if the patient is on clopidogrel or any of the newer antiplatelets, then we would stop these things after talking to the person who has started it, whether it can be safely stopped. Now we'd stop it for at least 5 days, 5 to 7 days before we take the patient up the procedure. And if it is going to be a diagnostic procedure, then no ecosprin. If the patient is on, we would continue the ecosprin. And if the patient is on any of anticoagulation per se, then we switch it over to a low molecular weight heparin. If it can be switched over, and then you continue with that, and then probably skip one dose of that and then do the procedure. But again, any of these patients would carry a much higher risk, and the discussion with the patient and the attenders would we need to include the fact that this patient carries a much higher risk than normal for bleed, and the indications and contraindications, the benefit of the procedure, everything has to be discussed in addition to the normal discussion that we carry out with patients when we do a diagnostic procedure. That is something that it has to be discussed and documented, whichever way that is appropriate.
So that's right. In fact, though we don't have the studies, we suggest that if you do a thoracoscopy in patients who are coagulopathy or who are on antiplatelets, there is a high risk of bleeding. But this is an elective procedure, and we should follow the standard guidelines from the British Hematology Society and manage the anticoagulant and antiplatelet therapy in these patients. That's very, very important. We can't afford to have bleeding in a diagnostic procedure and land up in difficult problems. So coming to Dr. Nitin, please. So you have stressed a lot about the use of the ultrasound guidance while doing the procedure, and it is mandatory now. It's a criminal if you do any thoracoscopic or even pleural aspiration without ultrasound guidance. It's actually criminal. So there are two ways we can go about. We can go with the X mark sign, where the patient is shifted to the radiology room. The radiologist marks the X point of the point of entry, and then he comes to the thoracoscopy suite or broncho suite, and you do the procedure. Other one is that you have a on-site availability of the ultrasound. So what would be the preference, and how would you go about? What do you think should be the right idea to do?
So if you really ask me, I think the best idea for a upcoming pulmonologist is to learn UHG yourself, mark it yourself. Only problem is going to be the licensing and the other issues. They will vary locally. So I think that is going to be a little bit of a problem. But at the same time, the fact that you have used ultrasound guide is good enough. The other way, very frankly, in my center, very frankly, we don't afford to every time, because we are just about 20 meters away. But even at 20 meters away, people are busy doing their routine ultrasonologies, UAG procedures. So what we do is, just before the procedure, one of my juniors goes there. He marks the best site for going in, and we also make sure that we mark the diaphragm in the highest position in the sense of expiration related excursions. So once we have done that, we are reasonably safe to go in because our mark is there. Of course, sometimes the mark really comes in a very weird place because the effusions are loculated there, and then you have to manipulate it in such a way that the drain is not going into the back of the patient and he's completely unable to sleep in the night. So that has to be adjusted. But once you take care of that kind of a scenario, most of the times absolutely real-time ultrasonography is, though mandatory, it is not practicable in every center. And we are talking of a country like India. We are talking of secondary, taluka places and jilla places where these kind of things, tertiary care centers have everything, and they can afford to do everything by the book and by the rule. But at the same time, it may not be realistic. So I think making sure that you have made an attempt and informed the patient in a correct way that, oh, look, these are the precautions that we have taken. We have had a CT, we have had a ultrasonography, we have had marking of the diaphragm in the best possible position, and then we have gone ahead with the procedure. And we have also made sure that by putting a needle, we have aspirated fluid enough to document that, yes, we are getting into the pleural space, fluid or whatever it is, air, depending on what we are looking at. So I think all these are good enough. I'm not saying they're ideal. The ideal way still will, in the utopian world, will be on-site sonography. Fantastic to have it. But then there are so many great things in the world everybody can't afford or everybody can't achieve. So I think there will be some compromises, one way or the other.
That's absolutely right. So ideally, you should have on-site ultrasonography available, but the X-mark thoracoscopy is a good alternative. But please do not do thoracoscopy without the ultrasound guidance in any ways, or in fact, any pleural procedure.
Absolutely. So if you ask me what is the standard of care today, I would have to recommend on-site ultrasonography. But there are times when we do it, or rather, 80% of the times we get away with, because there are moderate to large size effusions, and I mean, why have you become pulmonologists who are experienced? We are better than surgeons in many ways because we have understood things differently. And we have understood that okay, पहले plural tapping करते थे तो उस समय marking कहाँ होता था?
So I think we are running short of time, so move on to the next question, Dr. Nitin.
Please.
So this question goes to Dr. Swami. When as a beginner, you want to know how much should be the minimum fluid available to do a thoracoscopy. I mean, you can do a thoracoscopy in a patient who doesn't have any refusion. But for a beginner, I mean, what would be the minimum amount of fluid that would be required to do a thoracoscopy safely? What is your idea on this?
For the beginner, when you are actually trying to learn the art or you have apprehensions, then it is better to enter the space which has at least moderate pleural effusion, somewhere around 300 to 500 ml, so that the chances of hitting the lungs are much less. But as you rightly said, there are ways to create, even in a effusion lesser than that, you can actually use a pleural needle, introduce a pneumothorax and create it as a hydropneumothorax, create a space in the pleura so that you don't hit the lung. The most important thing is that when you are actually doing the dissection, when you are actually separating the intercostal muscle and you are going to actually penetrate the parietal pleura, that space is very, very important, because if there is some amount of force or some amount of miscalculation or too much of force, then you can end up hitting on the lung, and that can cause a severe injury. It can create a bronchopleural fistula, or it can create an air leak, or it can create an excessive bleeding. And when you actually enter the pleural space, your vision will be obscured. So it is very important as a beginner, you should select the cases which are simple. On the ultrasonography, though, it is very difficult to understand how much is the adhesions or how much is the loculations, and many times it can mislead you also. But USG is the reliably safe mode which can guide you. So as Nitin sir has said, it is
so as I get from you that in fact you should do an ultrasound and see that there is enough space between the parietal pleura and the visceral pleura, sufficient enough for you to introduce a trocar and cannula. Not actually the amount of fluid. What matters is how much is the distance between the parietal pleura and the visceral pleura, and have enough space for the introduction of the trocar and cannula. Very well said, done. Now, coming to a very tricky condition, Dr. Arjun, we talk a lot about the infection and sepsis, and we generally do not talk about the re-expansional pulmonary edema. In fact, one of the participants asked about re-expansional pulmonary edema, and it is a real problem. The two complications which I fear the most is infection and the re-expansional pulmonary edema. And if you talk to the various thoracoscopy, they'll say, no, we can remove liters and liters of fluid out without any problem. But re-expansional pulmonary edema does occur. It is not reported. We don't report our complications, as a matter of fact. Difficult to diagnose, but at least in my experience, I've got 5 cases of re-expansional pulmonary, when one of them actually died. So if you got a large pleural effusion, say fluid with a cavity with 2 or 3 liters of fluid, maybe 3 liters of fluid, how would you go about managing these patients for prevention of the re-expansional pulmonary edema, Dr. Arjun?
Very excellent point, Dr. Manoj, and like you rightly said, these are practical issues that you face, and on one hand, you are happy that you got a large effusion as a beginner to say that, okay, I'm not going to injure the lung. And then on the other hand, that there's always a chance that the patient would have a re-expansion pulmonary edema. What we generally tend to do would be that when you have a large effusion, we would probably the day before the procedure, we would try and tap out at least a liter or liter and a half, to try and see whether the patient is tolerating, whether the patient is having an improvement in dyspnea. Sometimes we even tap on 2 consecutive days and try and reduce it to a manageable amount when we are doing the procedure. So the problem is not when you're doing the procedure. When you're doing the procedure, so what happens is, once all the fluid is out, because you need to have most of the fluid out for you to have vision to see what is abnormal to take a biopsy. Especially when you're doing a diagnostic procedure, the patient is only under conscious sedation. The minute most of the fluid comes out, and because of instrumentation, the patient coughs, then there is a significant, there is a sudden expansion of the lung. And the sudden expansion of the lung with increasing expansion of the lung, the edema occurs and the patient coughs more, and then you lose the space. And when you're about to complete the procedure, or once you have completed the procedure, you have attached the chest drain and connected to underwater seal. All of a sudden, this happens. So, one is obviously to try and tap out as much fluid as possible in probably 1 or 2 settings before you actually take the patient up for procedure, especially with large pleural effusion. Second would be, we find, over the last 3-4 years, this cough component comes down significantly if you have these patients rather than under just conscious sedation. If these patients are more deeply sedated, the cough reflex sort of comes down, and you're able to have a more measured expansion of the lung. And third thing is, if the patient is not coughing, then you have the chest drain inside, and you feel that the patient, you have drained a lot more fluid than what you would normally drain. Then you can put in the chest drain and then clamp the tube. But this always carries the risk that if the patient starts coughing and you have a large parietal incision and a small skin incision because you have tied it quite tightly, this patient will have the air forced into the subcutaneous plane. Patient may end up with a large subcutaneous emphysema, which can be quite disfiguring to the patient, and can be the patient's attenders can be quite taken aback by the way the patient looks at the end of the post procedure. So these are certain things that you can do: a much deeper sedation, multiple tab before the procedure, and if the patient is not coughing, then you can try and clamp and reduce it, release the clamp slowly.
Excellent, Dr. Arjun. And this is one of the complications we should really fear and must avoid. That's very, very important, because this could be life-threatening, and it would be very painful. So please do not remove liters and liters of fluid in one go. The standard practice, a standard guideline, if you look at, is that do not remove 1.5 liter of fluid if the patient is tolerating. Do not remove more than 1.5 liter of fluid in one go. So that is standard practice we should follow as much as possible, even while doing a thoracoscopic procedure. Now, coming to another very important point. What is the typical...
I want to add one thing. I'm sorry to interrupt. I want to add one thing. In case we have around 2 liters of fluid, so after removing 500 or 600 ml, I tell my nurse to keep on keeping a count, because sometimes you forget it. Then I let the patient take 4 to 5 spontaneous breaths. So the fluid is replaced by air. So I have learned it with years of this thing, that you in between, if the patient is under sedation, you let him breathe on his own for 5 to 7 breaths and let the air go inside. So the fluid is replaced by the air, and that way we have less incidence of cough and less incidence of re-expansion of the lung.
Very well said, Dr. Pratibha. So when we are aspirating, when we are creating an hemotherapy, we should aspirate the fluid very judicially. We should not just take the fluid and suck the fluid very fast. It must be gradual, suctioning the fluid. At the same time, the air would go inside and, sort of maintain the intrapleural pressure. So that's a very well said point, Dr. Pratibha. Thank you. So I come to Dr. Shyam again. What are the typical pitfalls during the scope insertion? I mean, dissecting the thoracoscopy, dissecting the thoracic wall during this procedure, what precautions would you take? So
I feel space, you have to delineate the space very well. So for which an ultrasound is very, very important, a bedside ultrasound or a pre-procedure ultrasound. And the other, a very important precaution or a practice which I follow is, once I create a port, I actually sweep my finger around the parietal pleura just to ensure that there are no adhesions. And if there are adhesions, it gets freed. So once I'm happy there is space, I can insert my finger into the hole, and sweep the parietal pleura around, and then I proceed inserting the trocar. And the moment you should never force the trocar. I always try to dissect the pleura and try to get your finger into the parietal pleura and sweep it, and then you insert the trocar. That's my way of doing it safely and avoiding lung lacerations.
So what precaution would you take while dissecting the thoracic cavity? How would you,
So blunt forceps, Dr. Arjun had very nicely demonstrated in his video. Always use the blunt forceps the angle like he had shown, and open, never close the forceps and then come out. Always insert the forceps, split the muscle fibers or the tissue, and then come out with the forceps open. Never close it back and then pull it, because you might catch a vessel and then pull it out and it might end up in a bleed. If it's a patient like, CKD patients again, the skin incision itself bleeds a lot sometimes. So that time you can always have a monopolo cautery where you can cauterize the bleeding vessels at the edges of the skin of the incision and then go ahead. These are the basic precautions I would
Excellent.
usually
So
take.
you would make the incision on top of the lower rib, and
Yes.
would make only the incision, the skin, and rest of all is a blood dissection by the
Blood dissection.
artery forceps. So very well said, and this is very important point. You go inside with the closed forceps, but when you come out, then your forceps should be open. The prongs of the forceps should be open when you come out. So that's a very important point that Dr. Krishnan has, just elaborated. Now coming back to Dr. Nitin. So while doing the biopsy, which are the areas you would not like to biopsy? Right. So of course we are talking about the basics of thoracoscopy. So we are not going to biopsy the parietal visceral pleura at this point of time. So we are talking the parietal pleura.
Yeah.
So what areas would you still like to avoid while biopsying the parietal pleural lesions?
I think the standard of care teaching has been to take a biopsy on the rib by itself. That means you are not going to go into the intercostal space, and the risk of a intercostal artery getting torn is very less likely. But very frankly, by the time you reach the pleura for a diagnostic pleuroscopy also, the pleura is so very well taken up by the disease. And I've shown number of videos of that, granulomatous, nodular pleuritis, all kind of pleuritis. I don't think you can really in the true sense identify what you're biopsying. So I think that idea is great. When you are able to see the ribs and the interspaces, you take the biopsy on the rib. You are sure that you are not going to bleed. That's one. Of course, then using the pinch and peel technique is Arjun has beautifully demonstrated that in the videos that he showed. Pinch and peel will increase the yield, so that is not a problem. But I think if you really look at it from a diffused nodular pleuritis kind of a situation, where you take the biopsy, is almost impossible to really delineate between the rib and the intercostal space. And then I think that means the fact that you have so much of pleural inflammation, the fact that you will actually hit an intercostal artery is almost unrealistic. So I think you are safe to take a biopsy from wherever you can, and use the best area and use soft hands. I think the soft hands is the best idea to start with, and pinch and peel. That is the best idea.
And one area which I would not like to venture into is the apical pleura, where you got all the
there would be no sense.
Never try to take biopsy from that area. So
first of all, reaching the apical pleura with a rigid fluoroscope is almost nearly impossible. I mean, your scope tip will not reach there, and then having a control over their forceps, and then imagining the vessels. So I think it's a strict no-no. I would rather restrict myself to the 5th to 8th and downwards rather than upwards. And of course, don't biopsy diaphragm unnecessarily unless until you have no other area to biopsy. I mean, if there is a nodule sitting absolutely on the diaphragm, again use soft hands and take it from there, but you don't want to perforate the diaphragm.
Thank you, Dr. Nitin. So Arjun, where do you think the rigid thoracoscopy has advantage over the flexible flexi-rigid thoracoscopy? So could you please elaborate on that?
Rigid thoracoscopy, is definite advantage. So flexi-rigid, the thing that goes for it, it doesn't intimidate you. It's a easy transition for a pulmonologist to do it. But rigid thoracoscopy, especially, once you start, once you are through the learning curve, and we are talking about India, where you're going to be seeing patients who are going to have loculations, who are going to have septations, and most of the patients with a significant pleural effusion or a pleural-related complications are also patients who would not be able to afford the surgeon. One is afford the surgeon, and there is a dearth of thoracic surgeons who would actually no, things are improving in recent times, but surgeons who passionately do the thoracic work are far and few across the country, and especially if you're talking about surgeons who are going to be doing minimally invasive work in sense that you don't have a large incision and so those are the reasons, and that is the reason as to why you would once you're comfortable with flexor rigid thoracoscopy, if you're going that way, rigid thoracoscopy is something where you can do a little bit more. You don't have to spend a lot of time that the flexor rigid would take. There is no risk of damage to the scope. There is always risk of damage to the patient, but in flexor rigid, the scope is so fragile that other than what it is meant for, in the sense of taking a biopsy and coming out, if you try to do anything more, there's always risk of damage to the scope. So doing a little bit more for the patient, and as you keep pushing boundaries, you find that it does carry a lot of advantages. But for basic diagnostic procedure, then it depends on whatever you can get your hands on, and it is very well possible that somebody who is very good at doing diagnostic thoracoscopy would say that I would not want to do anything more than a flexor rigid thoracoscopy, and that is a fair enough call for that person to take, and still you would be able to handle about 75 to 80% of the thoracic cases that come to a intervention pulmonologist.
Very well said, Dr. Arjun. So possibly when you want to do a therapeutic work and you want to do a biopsy from a flat pleural lesions, where your biopsy force of the flexor rigid may just slip and may not come out with any tissue. So these are the areas, cases where you would go for rigid thoracoscopy. Otherwise, your flexor rigid thoracoscopy is good enough. And the diagnostic yield with both of them, both the technique is more than 90%. So anyways, I think Dr. Pratibha has to say something. Dr. Pratibha, please.
No, I think on 2 occasions I have to shift from rigid to flexible because the rib space was so narrow and the rigid scope will not enter. So practically we have to shift from, but otherwise what Arjun says stands good.
So we are not talking about, which scope is superior or inferior. No, actually, we should have both in our armamentarium, and, both are complementary rather than competitive to each other. So very well said. So coming back to Dr. Pratibha, to you, about the sample collection. So what kind of samples you would collect and how would you process them?
We try to take, in case the fluid hasn't been shed, we collect the fluid as well, because the shedding of the malignant cells is more in the pleural fluid, and whole of the pleura sheds the malignant cells in the fluid. So if the diagnostic tap hasn't been done, which is a rare scenario, but sometimes we do take a second sample of the fluid as well while doing the thoracoscopy. Then we take samples both in saline and as well as formalin. So if we have a clear-cut diagnosis of a malignancy, we have a mass and a fluid, we do not send for TB cultures or microbiological analysis in interest of saving money for the patients. But in case we have a doubt that it could be tubercular as well as malignant, we send the sample for gene expert and AFB culture in saline, and we send the sample for histopathology in formalin. So that's the standard practice which I follow. Means you can add more to it if you send it for other things.
No, it's good enough. I mean, most of the time we are doing for malignant pathology, infectious pathology. So that is the usual indications. And depending on the preclinical status, you would send your samples accordingly. And
I would like to add a point here. I started doing something little different, especially after reading the paper by the CMC colleagues. So they take a biopsy and they imprint on a slide. They smudge the sample and they call it imprint cytology, and they send that, and apparently the sensitivity is very good. So I started using that, and I also patients who can where we don't have financial issues, I always send a sample for frozen section also. So I feel that is one thing we underutilize in our setup, because then I can probably pleurodese the patient in the same setting if it's a malignant effusion. And then also cut down if it's malignancy, if shown in the frozen section, I wouldn't send for the tuberculous set and the infectious pathological analysis. So imprint cytology and frozen section is one thing I wanted to let the audience know.
Absolutely right. And other thing is, if you're suspecting infection, it particularly isn't looking like an empyema, you would also set the sample to blood culture bottles also. So that is again very important. So coming to Dr. Swami, what are the post-procedure usual orders you give to your patients?
Post procedure, you have to treat like your bronchoscopy only. Since you will be giving fentanyl and midazolam, you should keep the patient NBM for at least 2 to 3 hours. You should do a chest X-ray post procedure to see or check for the placement of your drain. And normally you should give an analgesic like simple paracetamol or diclofenac should be more than sufficient. The patient should be monitored. The SpO2 level should be monitored, especially you can continue the oxygen for probably 2 to 3 hours or till the time the hypoxia settles down, the patient cools down. And you should monitor his vital parameters for next 3 to 4 hours.
Absolutely right. So, you can't leave the patient on the table. The patient has to be monitored at least for 2 to 3 hours, depending upon his clinical condition. And one person must be actually, monitoring this patient and document it. So that's extremely important. Now, what about the chest X-rays? When would you order chest X-ray in these patients?
Normally, I order chest X-ray after procedure 3 to 4 hours, and the next day chest X-ray. But it depends. Like if you are planning to remove the chest drain on the same setting, if the lung has expanded, then you remove the drain and do the chest X-ray again, and you can send the patient home also.
So thank you. So Dr. Arjun, can you talk about a little bit of the post-op complications which can occur in these patients? You have done the procedure very safely, but still, you are monitoring them and observing something. And do you have any emergency support system for these patients?
Yeah, so like Dr. Swami said, these patients have to be monitored. So we monitor them for up to 4 hours in our recovery room, and then subsequently they get shifted once we see them or one of our fellows see them. There is a dedicated recovery nurse who monitors all the vital parameters. So that's something. So whether you're using a conscious deep sedation vis-a-vis general anesthesia, the most operative thing, the most common thing is, especially with patients with multiple comorbidities, is delayed recovery from these deep sedation and persistent hypoxemia, which can be there for a few hours. And if you're doing for patients who have comorbidities, a lot of them may have underlying COPD, and these patients, especially if they are not left not monitored, they can end up with carbon dioxide narcosis in the post-procedure patient and post-procedure time. And the other thing, the most common thing, and that is something that we have focused a lot in the last few years, is the analgesia aspect. The previous thing would be, since we have the luxury of having an anesthetist with us, and our anesthetists are very enthusiastic about regional blocks, and that is something that we have gone. So this way we are able to come away from a lot of narcotic like opioids that they're being used for these patients in the post procedure. So that way the patients are able to recover a lot faster. And once they are pain free, then they're able to take deep enough breaths so that the lung expands faster also, and they're able to mobilize. So what happens generally is in a diagnostic thoracoscopy, 2 hours post procedure, once the patient is completely up, or the patient is up and about walking in the recovery room, if the patient does not have any postural symptoms, that is under the guidance of the recovery nurse, and that is something that we have inculcated. So this also helps, especially in patients who are elderly. Only if you mobilize them, otherwise they tend to have urinary retention, and these are other complications that you can see in elderly patients. So good observation in the post procedure time, but that does not mean that the patients are going to be confined to the bed. There has to be a way in which these patients are mobilized fast. If they're mobilized fast, then we find that a lot of these diagnostic chest tubes can come out in 3 to 4 hours. That would mean that the patient is able to sleep well in the night. Even if the patient doesn't want to get discharged the same day for whatever reason, then once the chest tube comes out, the pain comes down significantly, and that improves the post procedure period also.
Very well said, Dr. Arjun, and covered a lot of aspects of post-procedure complication, especially the pain management, and which is the biggest, complaint in these patients. It's a painful procedure, and even after procedure, the patient may complain of pain, and which has to be, taken care of very, nicely. That's very important. Now, coming to Dr. Pratibha, when would you remove the chest tube in these patients? You have to unmute, Dr. Pratibha. Please unmute.
Yes, I have unmuted. It depends upon, as Shyam has said, that we are not using on-site histopathology or frozen section. If on the fluoroscopic picture, I'm very sure it is tubercular or something, even then I remove the chest tube the next day when I have got the reports with me. In case it is malignant, and I'm sure on the table and patient has another mass, and that is my preclinical diagnosis, and I do the fluorodesis on table, I'll do a talc podraj. Then it depends upon the drainage output, and I still not remove it after 24 hours. I still wait for the pleural discharge to decrease below 300 ml before I take out the tube. My practice might be slightly outdated, but that's what I practice. In case the next day the report comes out to be gene expert positive or the granuloma, I take out the tube then and there after 24 hours. So I rarely take out the tube 4 to 6 hours or on the same day of my doing the procedure. I still take minimum 24 hours before I remove the tube. So,
very well said. So if you have got a pre-test possibility of tuberculosis and the lesions look like tuberculosis and the lung has expanded, and if you do a chest X-ray, the lung is expanded and there is no fluid, drain for 4 to 5 hours, one can decide on removing it.
right.
The point is, many times our patients have a lot of pain, complaints which are there. We have a population which is quite pain sensitive. So, we talk a lot about daycare, thoracoscopy, remove the tube, send them home. And with, comorbid conditions it is. So preferably in our setting, it's better, especially for the beginners, better to, keep these patients admitted for at least a day. And if there is no drainage of the fluid in next, within 24 hours, and the lung is fully expanded, you can remove the tube most of the time, until you are contemplating doing any sort of a talc insufflation and other things. Anyways, so coming to the end of our discussion, coming to Dr. Nitin, how many procedures to be done per year to maintain a proficiency? I mean, you have covered in your presentation, but this is
it's worth repeating.
Yes.
Because 15 under as a trainee, under supervision of somebody who is experienced, and then at least 10 procedures a year is what is recommended by the ERS or most of the international guidelines. So I think 10 procedures means roughly it comes to at least a procedure a month, and preferably you are going to do it not just 1 year but year after year. So I think it's not something which is only done for a year and you have achieved proficiency forever. So I think that is something which is worth keeping in mind, that I think you keep on doing it forever. And if you keep doing one procedure a month, next year you are usually going to do 2 and then 3 and 4. So I think that experience keeps growing.
Thank you, Dr. Nitin. So I think we have covered most of the part of the basics of thoracoscopy and rigid thoracoscopy in particular. And we have addressed majority of the issues. There are a number of questions in the chat box, which are required for the advanced thoracoscopy procedure. And we are going to have 9 more modules where these points would be discussed. And so we leave it these questions to be answered in those sessions. I thank all the panelists, all the eminent speakers, and the audience who joined in from all over India and across the globe. I thank the IAB and Dr. Amita for organizing this event. And just to summarize the whole session, I can say that the rigid thoracoscopy is now something that we should learn. It's actually an extension of the therapeutic, the basic thoracocentesis and chest tube drainage, and it's very easy to learn. One intervention which you can learn in your interventional career early and practice it and excel in this. This procedure is mainly done in conscious sedation with the local anesthesia, and therefore it's also called the local anesthetic thoracoscopy, or LAT in short. Basically, it is done, a majority of time, it is done as a diagnostic procedure where your target is the lesion in the parietal pleura, and you would avoid lesions in the visceral pleura until as the lesions are too large, and you expect that biopsying this lesion will not lead to the laceration of the lung and subsequent bronchopleural fistula. Can be done in patients who are relatively stable, who do not have undue hypoxia because of other reasons. You must rule out the contraindications. Do the procedure only when you're confident of doing the procedure, and anytime you think that the procedure can lead to complications which you cannot handle, it's always better to ask your surgeons to do that procedure. And having said that, a backup ICU facility and a backup of a thoracic surgeon is a real advantage, in doing these procedures. And please befriend with them, because if any complication occurs, they are the people who are going to come to your rescue. It needs some sort of a training. It needs some sort of a mindset change that it has to be done like a surgical procedure, and all aseptic precautions have to be taken. And you should be mindful of the complications which can occur during the procedure, intraoperative and post-operatively. Delayed, occurrence of re-expansional pulmonary edema and other complications is always a possibility. So always keep a check of these patients and follow them very carefully. You can do a daycare thoracoscopy in case you are confident you got the enough backup, where should the patient develop a sort of emergency, you are able to provide that kind of emergency support. Otherwise, it's better that you keep this patient, depending upon your facility, at least for a day. You can choose to do a intervention as you get trained, and this is something that is going to be covered in subsequent lectures. So with this, I would again thank all our eminent speakers and all the audience who have joined in, and thank IAB and Dr. Amita for the support, and also the support staff there, CIPLA, for organizing this event. With this, I say goodbye, and once again, thanks to all from the bottom of my heart. Thank you very much.
Thank you so
Good
much.
night.
Thank you.
Thank
Thank you, sir.
Thank you.
From the team IAB, I would like to heartfelt thank you to Dr. Manoj Goyal for moderating the session. Sir really took it as
You
a
did a
captain of the
wonderful
ship.
job. Absolutely great.
Wonderful job, sir. And thank you to all the panelists and the speakers and all the people who joined in and stayed back so late. So it's a wonderful start for the webinar marathon that we have. And hopefully we'll catch you all in the hands-on session.
Thank you
Yep.
so much.
Thank you, Mehul.
Thank you.
And
Thank you.
thanks the team IAB, Dr. Nene, for taking this wonderful initiative. Excellent initiative.
See you all. Good night.